So all these drugs have both a generic name and a trade name, and the ones that are very common in the United States are things like hydrocodone, which has lots of names, Loratabs, Vicodin, people probably heard those names, and oxycodone, which has had a especially sordid history, and I thought about talking about oxycodone more thoroughly. Oxycodone is a wonderful medicine that unfortunately got a terrible reputation when it came out as a drug called OxyContin. OxyContin is not a particularly bad medicine, but unfortunately it was very easy to misuse and ended up on a market and was diverted fairly easily and caused a lot of the initial problems. But there's a lot of oxycodones. There's Percocets and Percodan and Roxicets. Right now, Roxicets seems to be a very big drug in this particular area. It's a kind of oxycodone that's really very easy to alter and misuse, and you can crush it and snort it and inject it very easily. The original forms of OxyContin, which were so much problem for about 10 years in the United States, the company has made a new formulation of those medications, and because of that, the new formulation makes it much more difficult to divert. You can't really crush it, you can't really snort it, you can't really, if you can beat on it and melt it and put it in a microwave and do all sorts of things, but it just doesn't, it loses its vitality. About the only thing you can do with it is take it as a pill, and most drug addicts just don't want to take medicines as pills, they want to misuse the drugs, and so they want to snort them or inject them or whatever, and so the new forms of OxyContin are not nearly as desirable on the street as they used to be for the first 10 or 15 years of their existence. You can also see, well, you can see all of them up there, hopefully you can see that. The bottom one down there, by the way, heroin, most people don't realize heroin is a trade name. Heroin, that's one of these things that's in common vernacular and we don't really think about it very much, but heroin has a generic name. Heroin was diacetylmorphine. Heroin came on the market as a legal drug in the United States in the late 1890s, and it came on the market. Maybe I have a slide or two. Let's go to the next. Let me see. Oh, I'll come back to the heroin story in a minute. These are the other drugs that I need to talk about. These are the ones that are sort of not full opioids. The first group I showed you are really what we call full opioids. They do all the things that a regular opioid is supposed to do, and I'm going to tell you about that: pain relief and sleep and all these things. These are partial opioids. They tend to be a much safer group of drug, which work a little bit like an opioid, but they work a little bit like an anti-opioid too. And again, I'm going to tell you about that here in a bit. But some of these are very important. Obviously, buprenorphine, which first came out as Buprenex, is a drug that has been very useful. I'm going to talk about it a bunch here in a little bit. It's called Suboxone. And then there's a couple others up there. Some people may have heard of Stadol. We went through a little epidemic of Stadol addiction here in the early 1990s. And Talwin was a very popular drug 30 years ago, but almost nobody liked it because of the long-term side effects. When you injected Talwin, you ended up getting all these scarred muscles and things, and you got contractures, and even the addicts after a while said, this drug is just not all that much fun. Okay. So I don't want to teach a lot of biochemistry or a lot of neuroanatomy because I'm sure that, well, this kind of stuff gets me really excited almost to the point that I feel like I have to race to the bathroom. Most people here probably would not be that excited about this sort of thing. But this is the neuroanatomy, and if you're an addiction psychiatrist, this is the area where we live. This is the area that gets us all excited and makes us want to jump up in the morning and say, yes, we can work on this area. It's called the mesolimbic system. And basically what I'm showing you here is a half a brain. If we took a knife and cut you right down the middle here, literally right down the middle, you'll see right there in the very kind of center, there's this area called the nucleus accumbens. And the nucleus accumbens is about as big as your little fingernail. And it's really located right deep inside the brain. And it's located in a part of the brain that's very hard to get to, very well protected, and historically is very old. It is the pleasure center of the brain. This is a part of the brain that not only humans have well developed, but a lot of animals have well developed. It's the part of the brain that experiences reward. So anything that is felt to be good by the animals is rewarded by the animal, is rewarded by the human beings. If something feels good, the reason it feels good to any of us, whether it's sex or meal or drugs or whatever it is because there's chemical changes that are going on there in the nucleus accumbens. If something doesn't make the nucleus accumbens quiver, we're not going to find it exciting. So, for example, if you take cocaine or you take Oxycontin or heroin or one of those drugs, or nicotine, if you use any of those drugs, you will find out that the nucleus accumbens will light up. It will spew forth and get real energized. And by the way, when it does, you'll see there's an arrow that leaves the nucleus accumbens and goes up to this area in the front of our brain called the prefrontal cortex. And we as human beings say, oh, you know, that is really good when that happens. So you do cocaine or you do heroin, all of a sudden you say, oh, that felt good. And it's right there, and your brain's thinking, yeah, that was good. Now let's see, what was I doing? You know, who was I hanging out with? How do I get some more of that? I mean, it just, your whole part of your cognition, your willful cognition says that was really good, and I think I might want to do that again. However, the arrow, unfortunately, only goes one way. The arrow goes from the nucleus accumbens up to the prefrontal cortex, but the prefrontal cortex does not speak to the nucleus accumbens very much at all. And that's really the problem in addiction. That's the reason, in a very basic way, why a drug addict or an alcoholic cannot merely will themselves to quit using. Because, and I'm going to skip ahead here a little bit, if you're hooked on drugs, and after a while, every drug addict says, you know, I got to quit this stuff. It's tearing me up. You know, I'm in trouble with the law. I got to go see Angelo all the time. You know, I got to go see the judge. I got to go see Dr. Sullivan. You know, I just got to quit this. My wife's after me. I've spent all my money. I've lost another job. This is terrible. I feel like crap. I need to quit. I'm a smart guy. I need to quit. That's the prefrontal cortex thinking. Prefrontal cortex is thinking, you know, I need to quit. I've learned my lesson. I am done. The nucleus accumbens, which is where addiction takes place, is laughing its little rear end off because it knows you have no chance at all of quitting. There's almost no connections that go from the prefrontal cortex back to the nucleus accumbens. You cannot will yourself to not feel that pleasure anymore. The nucleus accumbens, anything that is pleasurable to the animal will be likely to occur again. That's the way it's set up. That's the reason that we eat again. That's the reason we continue to have sex and propagate. I mean, it's the reason we do things over and over again, because anything that's perceived to be pleasurable, we're going to do again. The nucleus accumbens is located, by the way, right near your memory centers, too. I mean, those two things are intimately tied together. A lot of people think they have control over their nucleus accumbens, and every addict, every smoker, everybody says, you know, I'm just going to quit. I'm just going to stop. And if all you had to do was say that, everybody would just quit. Because there are a lot of addicts that have all sorts of trouble. They need to quit. A lot of alcoholics need to quit. But they can't quit. And it's not because they're weak people. They can't quit because they have serious altered brain changes that have occurred in their primary reward center. And just thinking about quitting rarely is successful. If it was so easy to do, everybody would just do it. Because I can tell you, all these people that are in jail, do you think they really wanted to end up in jail? They all wanted to quit, and they just couldn't. It's just not that easy. That's the way addiction works. And I think for people who aren't addicts, that piece gets lost. It's not really very well understood that these people have profound brain changes, and just saying don't do it is not going to work. Okay? The reason people get hooked on Oxycontin or hydrocodone is because when they do hydrocodone, it lights up their nucleus accumbens. The reason people don't get hooked on broccoli is because you can crush broccoli, you can snort broccoli, You can rub broccoli, you can do whatever you want to with broccoli, and it does nothing to your nucleus accumbens. It's going to say, come on, bring on that, I want to smoke some more broccoli. It just doesn't happen like that. There's no chemical in there that's going to light up the nucleus accumbens and make it a reward. Okay? Next slide. So opioid effects. What happens when you take opioids? Well, as you can see up there, you get an almost near instantaneous euphoric rush. It almost doesn't get any better than that. People who do heroin, they will tell you this all the time, but any of the opioids, they make you feel really good almost instantaneously. They light up the nucleus accumbens. And as you can see this, it says it hits the opioid receptors in the brain. You get this massive release of chemicals. Now, what happens if you do too much? The first thing that happens is people feel real good, but if you do too much, you actually start to slow down your respiration center. You start to make yourself go to sleep. You can see, feel relaxed, sedated, drowsy. Some addicts will talk about if they do too much, they kind of want to nod off. All those are direct effects of the opioids themselves. If you do too much, you get respiratory depression, which basically means you slow your breathing down. If you do too much opioids, you go through this whole stage of feeling really good to kind of nodding off to slowing your breathing down. One of the things they told us back in medical school was if you slow your breathing down too far, that's not a good thing to do. That in fact, eventually you might quit breathing altogether. Okay. Opioid toxicity, I suppose people remember Heath Ledger. Hopefully they do. Probably in a few years I'm going to have to put up a new actor or a new famous person, but how toxic the various opioid drugs are really have a lot to do with how pure they are. And most addicts, you have to understand, would prefer to take prescription opioids. They would prefer to take something they could get from a doctor because they know they're pure, they know what they're getting. Most addicts don't like to go to heroin. I don't know if you are aware of this. People will use heroin for a number of reasons. It does, because you inject it or smoke it, it does give you a very quick rush. But the problem with heroin is that you never know about the purity you're getting. And sometimes it's good and sometimes it's really good and deadly, and sometimes it's almost junk. It can vary from 5% to 95% pure. I mean, there's just no quality. Nobody makes heroin. There's not quality. You can't just go buy pharmaceutical heroin anyplace. And so, you know, how toxic opioids are really depends upon the purity of the drug itself. And so, again, most addicts that I take care of would prefer the prescription pills. And you have to understand, all those pills I showed you before, heroin is just another one of those pills. All these drugs are just different colored M&Ms. Maybe I need to make sure I say that, because people think there's a lot of difference between heroin or oxycodone or morphine or hydrocodone or Dilaudid or any of these other things. They're just different colored M&Ms. I mean, that's how close they are. There's not that much different. Some are more potent than others. Some are way more expensive, but basically they all do the same thing if you get the doses right. The big problem with opioids is that people tend to mix it with other drugs, and that's where you really see a lot of the toxicity. They tend to drink with it, or, you know, over time, you know, your tolerance changes. It just depends. But some people. But opioids can be really toxic depending upon what combination of drugs you happen to be using at the time. And what I've described up there is what happens. You go to coma, you go to respiratory depression, you quit breathing, your lungs fill up with fluid, you lay there, and basically you look like you're going to die, and then you do die. And let me just give you a really quick story, because I think all doctors have seen this, which will also tie up here with this last thing. It's reversed by naloxone, this drug called Narcan. When I was a young resident, I saw a patient who came in who was laying there, exactly what I just described there. They were completely out of it, cold, blue, no skin, hardly breathing at all, almost no pulse, and they're there in the emergency room. And somebody suspected maybe it was a drug overdose, and so we were able to get an IV in them. We gave them a little bit of Narcan, which is the last thing up there, which is anti-opioid. Narcan is an anti-opioid. We got that in the vein, and about between 30 and 45 seconds later, this guy literally looked like he rose from the dead. I mean, he went from not breathing, all of a sudden his eyes popped open, he went up, oh, well, he said some nice words at that point. because we had thrown him into unbelievable opioid withdrawal. He came up off that and he's shaking like this, you know, and we had basically reversed the death process by giving him the right drug. And we were all real happy with ourselves because we knew we'd saved him. We had just thrown him into terrible opioid withdrawal, and he was really very unhappy. He didn't realize he'd almost died, so he's cursing us out. You know, it was one of those lovely scenes that occur in emergency departments sometimes. Okay, next. Opioid withdrawal. Opioid withdrawal is not life-threatening, but it must be so bad that the average opioid addict will crawl over broken glass on their hands and knees in a driving snowstorm to make sure that they get their next fix rather than go through opioid withdrawal. What happens when you go into opioid? If you go into alcohol withdrawal or sedative hypnotic withdrawal, you might die. There's no question. You could go into the DTs and die. If you go into opioid withdrawal, you're going to sweat, you're going to shake, your nose is going to run, your skin is going to leak, you're going to get diarrhea, you're going to vomit, everything is going to ache. And it's often described as being like the worst case of the flu that you could ever imagine, because these people do really look sick. But if it's pure opioid withdrawal, they are not going to die. Nevertheless, while all these physical symptoms are going on, inside their brain there is a craving that's going on that is so completely overwhelming that they will drag, as I said, they will drag themselves out the door, and they'll walk all night if they have to find drugs so that they can take something so they can feel better. Opioid addicts describe this routinely, this incredible compulsion to use in ways that, if you're not an addict, is almost impossible to imagine. You know, one of my challenges with the medical students is to get them to understand that their experiences may be very different than the addict's experience. Addicts, once your brain becomes addicted, you have so little real control over what you're going to do. You know, you think because they're walking and talking and speaking English and you're talking to them and they say, oh, I'm going to quit and I've learned my lesson and I'm not going to do this. It is all baloney most of the time. They're lying to you while they're lying to themselves, because their addicted brain is demanding that they go out and find some more drugs in order to try to feel normal. And that's the real brain change that goes on with drug addiction, and I think most people don't appreciate. And maybe I digress here a minute, but one of the problems we have in society is we have to separate the disease of addiction from the bad things that addicts do. And those two things are very different, and for a lot of the public out there, they really get these two things mixed up. Because addicts will steal stuff or they lie to you, you know, they become these bad people, and addiction is bad. But there's no question addicts have a very severe, complicated brain disease that is difficult to treat, and because of that they do a lot of bad things. But those are very separate issues, and I think we need to make sure that we pay attention to that. I spend a lot of time, you know, talking to patients and treating and teaching students that you have to be able to separate that, because a lot of medical professionals come into this whole field with the notion, with a lot of wrong-headed notions about what an addict is and what they need. Okay. So medication treatment of opioid dependence. We really have three. I'm going to talk a little bit about the first two, methadone and buprenorphine. Naltrexone I'm not going to really talk much about. I think there's somebody else that has spoken about that. That's a drug that's has two different forms. One's called Revia, which is a daily medication people take. The other one is called Vivitrol. Naltrexone is an anti-opioid. It basically blocks opioids, and so some people will be put on this drug as a way of sort of preventing them from relapsing, because if you're on this drug and you take, you know, another opioid while you're on an anti-opioid, basically nothing's going to happen. I could talk a lot about that. I haven't had very good experience with that particular drug. I know there's others that have had better experience with it who may be able to speak more eloquently about naltrexone. I'm certainly aware of it, and I know its usefulness, or at least its purported usefulness. I do want to talk about the other two treatments up here, methadone, buprenorphine. I want to go through them somewhat quickly. Go ahead. I want to just mention methadone maintenance treatment, not because I'm particularly an expert in this, but because I've had to learn an awful lot about it over time, and because it's also a very useful treatment for a lot of patients. And certainly I suspect the audience has heard about methadone maintenance. Go ahead. Methadone maintenance, well, that thing 1915, the Harrison Narcotic Act, I only want to mention that because as of 1915 in the United States, it was illegal for a doctor to treat an opioid addict in the United States for addiction. I know it seems crazy now, but between 1915 and actually 1970 or so, it was illegal for doctors to treat opioid addicts for addiction. You could treat them for a lot of other things, but you couldn't treat them with any kind of medication that would help them. There's all sorts of political reasons that go back to prohibition about this that wouldn't necessarily make sense in today's market, but nevertheless that's the way it was. There was a problem with heroin starting after World War II, and a guy named Marie Neiswander and Vincent Dole in the mid-1960s said, well, you know, we got this drug methadone. If we could put these heroin addicts on methadone, daily methadone, maybe that'll stabilize them so they'll feel okay and be able to go about their business and quit having to run around town and raping and pillaging and stealing and robbing and doing all these kinds of things to get their drugs. And it turned out that worked really well, by far better than anything else we'd had. In the late 1960s, early 1970s, methadone clinics, which were very highly regulated and still today are the only medical treatment that is designated by the government as being has to be in a specific federally run program. They came into existence. Methadone clinics still today are not allowed to be in regular hospitals or clinics. They have to be separate. I mean, there's all sorts of political reasons why this was, but they have to be their own separate entity and very highly regulated. Okay. The idea with methadone was to give methadone and people would stay clean for 24 hours. The idea was to stabilize their brain basically so that they felt okay and they wouldn't go into withdrawal. Anyway, there's the dose. The average dose was 30 milligrams. Most people are on somewhere between 60 and 120 milligrams. You have to go every day to one of these clinics until you've shown that you're really stable and that you're doing really good, and then you can start to get some take-home doses. Go ahead. The third bullet up there is important, and that with methadone maintenance there is no arbitrary maximum. For a long time people were giving a little bit too low a doses and folks weren't doing very well, but there is no arbitrary maximum. I've seen some people on some huge doses. Again though, once you get over about 120 milligrams a day, that's getting to be a pretty high dose of methadone. Go ahead. Methadone over the past few years has been increasingly used for pain because it's an opioid. It's a very long-acting opioid. But that has come, and it's a very cheap opioid, very cheap. And so as OxyContin and hydrocodone and oxycodone got kind of a bad reputation, a lot of doctors sort of switched pain patients over to methadone. And for some it worked pretty well, but it turns out there's a danger in this. Go ahead. Go ahead. Methadone is a little bit sneaky of a drug because unlike all the other opioids, whether it's heroin or oxycodone, any of the other opioids, when you take those, it really hits the brain very quickly. Methadone takes, you know, when you swallow it, it takes a while. You know, it takes an hour or two before it starts to kick in. It's much slower than the other opioids. And so what's happened, methadone, there's been an awful lot of deaths associated with methadone in the United States, especially over the past few years. And I don't know that I want to go into all the different ways that occurs, but a lot of the reasons it happens is because methadone enters into the system so slowly that people tend to take too much of it before they realize they took too much of it. That's what happens. So people will take 30 milligrams of methadone, and a half hour later they don't feel anything. So they take another 30 milligrams, and then half an hour later they don't feel anything. And then they take another 30 or 60 milligrams. By then they start to feel something, but by then they have taken a lethal dose, so that 2 hours or 2.5 hours after they started, all of a sudden they're in methadone opioid overdose. That's what occurs with methadone. Go ahead. So I just put this in. This is the most frequent contributory drugs of unintentional overdose in West Virginia. You can see 2001, 2006. What I put up there, and I want you to see, is that methadone was the drug most associated with unintentional overdoses and deaths in West Virginia. What we listed up there is the top 10. Of the top 10, 6 are opioids. So 6 of the top 10 drugs listed as what has killed people in West Virginia, unintentional drug overdoses, were opioids. And 3 of the others were sedatives. Diazepam is Valium, alprazolam is a drug called Xanax, and alcohol. Those are all sedatives. So 9 of the 10 were either opioids or sedatives, with the other one up there being cocaine. But methadone is a particularly lethal drug on the street, can be. Now, this is really important, because the methadone clinics, and I could sit up here and beat on the methadone clinics, because there's some things I like about them, there's some things I don't particularly like about them, but most of the methadone associated with overdoses does not come from methadone clinics. Most of it comes from pain clinics, from doctors who write methadone for pain and then it gets diverted. Okay? Now, I want to get to this. This is, and then I'll open it up to questions. I got several slides here I want to go through. The Drug Addiction Treatment Act of 2000. This is, you know, again, I could get all quivery and excited talking about this. I'm sure you all might find it incredibly boring. But what this act did, for the first time since 1915, was allow doctors to treat patients, opioid-addicted patients, in their clinic. Seems kind of crazy, but it took, what, 85 years, and we were able to then start to treat patients in our clinics for opioid addiction. And it allowed us to use certain kinds of medications that had been FDA approved. As it turns out, we'll go to the next slide. As it turns out, there has only been one medication that has been approved for doctors to use in their office for the treatment of opioid addiction, and that's buprenorphine, which I mentioned earlier. Buprenorphine was FDA approved in the early 1980s as a pain medicine called Buprenex. And because of some really incredible studies that were done in the 1990s, the FDA approved buprenorphine in late 2002 for the management of opioid dependence, and 2 versions of buprenorphine came on the market. And I hope everybody in here knows these names. One of them was Suboxone, which is a combination medicine, and the other one was Subutex, which is just pure buprenorphine. They came on the market and were FDA approved for both detox and maintenance. I could not tell you how important and how helpful that was. I had, by 2001, 2002, I got this close to doing a methadone clinic in West Virginia. Not because I was a huge fan of methadone, but frankly because I was so concerned that all my patients were dying. You know, for me, the low point, and maybe I'll just digress a moment here, the low point in my medical career was about 12 or 13 years ago, when I had patient after patient come into me hooked on opioids, prescription opioids for the most part, high-dose prescription opioids. I would bring them in the hospital, I would detoxify them, and I would send them out the door and send them to NA meetings, try to get them hooked into therapy, try to get them to do all the things they would normally do, and almost all of them relapsed. And at that period of time, it seems kind of strange now, but at that period of time, hardly a week went by that one of my patients didn't overdose and die. I mean, there was a huge number of patients. Hardly any doctor was willing to see them, and we didn't have much to offer them. They were dying. And I could sit here and tell you several stories of people I really liked who are no longer breathing air on this earth, who I'm sure died accidentally. It was a really low point in my career. And because of that, though I didn't like methadone, I did get fairly close to starting a methadone clinic. And just when I started to actually fill out the paperwork to get a methadone clinic going, buprenorphine in the form of Suboxone and Subutex came on the market. I thought it was never going to come on the market. I'd been hearing about it for years as a physician. I knew about it since the mid-1990s, but it just took forever. And finally, it just came on the market in late 2002, and in January of 2003 I started to use it, and I'll tell you some more about that in a minute. Go ahead. Buprenorphine is a very unusual medicine, and it's also very, very useful because it's unusual. Buprenorphine is not an opioid per se. It's a partial opioid. And what I tried to do up here was show this slide that on the left side shows really pure the pure opioids, things like heroin, morphine, methadone, hydrocodone, oxycodone, all the things I've been talking about. They're all pure opioids. On the right side up there are the pure anti-opioids. We call them antagonists. And it's things like naloxone and Narcan, which I've talked about previously. Buprenorphine is a partial opioid. It's right in the middle. At low doses, it acts like a regular opioid, like the ones on the left. At higher doses, it acts like an anti-opioid, the ones on the right. And those characteristics of buprenorphine have made it very useful and also very safe. Okay, go ahead. I think I don't want to show it. This is a good slide, but I don't think I want to show it. Go ahead. What I do want to show is this slide here, because this kind of emphasizes what I was just telling you. At low doses, way over on the left side there, when you give buprenorphine at low doses, basically you'll get an effect. So people get pain relief. They might get, they might start to dry up. Their bowels might, all the things. They might get a little sleepy. All the things that might happen with a pure opioid will happen at low doses. But as you go to the right, as you move to the right, you'll get this effect of buprenorphine where it keeps working kind of like an opioid. But at some point, it levels off. When you get up in sort of an average dose around 16 milligrams or so, you basically are not going to get any more effect. And if you keep giving patients more buprenorphine, if you keep giving them more Suboxone, if you keep raising the dose, what actually has, it's a bell-shaped curve, they start doing worse. So you see people on 28 milligrams or 32 milligrams or even higher, what happens is you'll find out the patients are not doing very well at all. And to emphasize that, let me just tell you this story of a guy. If I took any of you guys here, first of all, if I took any of you guys here and I put you on morphine, I just kept raising the dose, that graph would just keep going straight up until you got up to a point up here where you quit breathing and the ball game would be over. There was a guy that came to me about 8 or 9 years ago, who'd been to Cleveland, got put on Suboxone, and he had gotten put on 36 milligrams twice a day. So he was on 72 milligrams. Now, that is an enormous dose. At 72 milligrams, and his complaint to me was, he said, "Sullivan, I'm doing terrible." He had terrible diarrhea, he had terrible shakes, he was sweating, he was leaking, his nose was running. He looked like he was in unbelievably bad opioid withdrawal, and yet he was on 72 milligrams of Suboxone. And I knew what was going on. What was going on is he was way over the hump. He was way down here on the right side of this curve. And if I just backed his dose of Suboxone down, he'd feel better. So all I did was drop him from 72 milligrams a day to 12 milligrams a day. Dropped him 60 milligrams of buprenorphine. He came back the next week. He thought I walked on water. He felt so good. He just could not believe it. He was on a fraction of the medicine he'd been on before, and he felt absolutely fantastic. And the reason was, again, it's a characteristic of Suboxone, is that he was on way too much. He was getting into the anti-opioid effects. That's not what you want to do with this medication. You want to get them on just a low enough dose that you stabilize their brains, but you don't want to give them too much. It's very safe in that way. Okay. In Europe, the problem with buprenorphine in Europe was that pure buprenorphine was misused. A lot of people would inject it. They would mix it with tranquilizers or whatever. They'd inject it, and there was a lot of deaths in Europe. Because there was a lot of deaths in Europe, when it came to the United States, there was an insistence that we had to figure out a way to make this drug as safe as absolutely possible. And so what they did was they took buprenorphine and they added a little bit of anti-opioid in terms of a drug called naloxone. And they made this combination drug. And so Suboxone, which I suspect most people in here have heard of, is really a combination drug of buprenorphine and naloxone. The only reason that the naloxone is in there is to keep patients from injecting the medicine, because if you crush Suboxone up and you injected it, you'll get sick. And so it's really put in there. The FDA insisted that they put it in there to keep people from misusing it. Okay. So the forms of buprenorphine we have in 2013, it's a constantly changing scene. As it turns out, Suboxone, we have it. It's a trade name made by a company called Reckitt-Benckiser. And it's the combination, as you see, buprenorphine, naloxone. And then we have generic pure buprenorphine. We no longer have the Subutex available, but there's several pharmaceutical companies now just making this generic buprenorphine. Okay, go ahead. It comes in several different strengths. There's 2 old strengths. There's 2 new strengths that have just come out in the past month or so. It's hard to know how that's going to play out. There is no Suboxone. There used to be Suboxone tablets. The tablets have all gone away now. The only thing we have left is the film. And so if you hear people talking, and I'll show you a picture about this in a minute. If you hear people talking about the film, that's because that's the only thing around now. Okay, and this is it. Until recently, there is still a little bit of Suboxone tablets. That's it there on the right. It's going to be phased out here in the next couple or 3 months. And virtually everybody who is on Suboxone now in the United States, virtually everybody will be on the film. Actually, in West Virginia, it's the state law that if we're going to use Suboxone, we have to use the film, interestingly enough. We don't have any choice, with a few exceptions. And I'll talk about those in a minute. Okay. So I put up here a bunch of general questions, and then I may just, if anybody in the audience has any questions about treatment and addiction, I will certainly be willing to ask them. But I put up some questions that people have asked me over time about this medication and how I use it in treatment. And hopefully this will answer some of the questions that people may have about this medication. So who might benefit from Suboxone? What patient might benefit? Okay. And the answer is patients who need opioid detoxification, patients who want an alternative to methadone, patients who have been unable to refrain from use of opioids, patients with dual diagnosis, and some chronic pain patients. And I'm going to come back and talk about chronic pain a little bit. As an aside, and I'll say this, I think I'll say, no, I'll come back and talk about that too. I'm going to try to make this flow in the way that I want it to. Okay, next. So when do I start Suboxone? These are questions people ask. And the answer is you don't start Suboxone until a patient is in withdrawal. They actually have to be in opioid withdrawal. If they're not sick, if they're high on heroin or high on morphine or high on oxycodone, and I give them Suboxone, the chances are very good they're going to go into opioid withdrawal and get sick. So all the patients I see are already kind of what we call dope sick when I see them, and that's when you start them. It's pretty easy to get people on this medication, and thankfully so, because there's so many people that need to be in treatment that I'm actually pretty thrilled that this medicine is easy to use. The biggest problem we have is if somebody is on methadone and they want to switch over to Suboxone. That's a very tricky thing to do, and I could end up talking a long time about how you do it, but it's very tricky. Okay. So these are the symptoms you get in opioid withdrawal. When people are sick and in opioid withdrawal, basically, I told you, it's like looking like it has a bad case of the flu. The other thing that people will say is that if it can leak, it does. Your nose runs, your bowels run, you puke, your skin leaks. I mean, everything's leaking. Everything's drippy and wet and runny. And I can't tell you, I bet I have shaken 1,000 hands that were cold, wet hands. People who are doing this, shaking. You know, and that's just what happens when people are in opioid withdrawal. Everything kind of is leaky and runny, and it's just, I mean, they feel really sick. Okay. So what Suboxone dose do I take? And initially, day could vary 4 to 12. Stabilization only takes a couple days. The average dose in the United States is between 8 and 16 milligrams. Now, I need to say a word about that because I'm also aware, and this is a big problem in the treatment of addiction right now, is that there are a number of people, there are a number of patients who are on doses much higher than 16 milligrams. There is almost no medical justification for that. A lot of addicts, you know, what's an addict's favorite? I used to hear this in NA. What's an addict's favorite drug? More. What's their favorite drug? It's more. Whatever you got, more. And so a lot of patients will go to the doctor and say, oh, you know, 16's not working, I need 24 or 32 or whatever. And so patients will get way more medicine than they need. The truth of the matter is that there's been very few patients. I've only seen 2 patients who needed more than 16 milligrams of Suboxone in a day. 16 milligrams of Suboxone is a huge dose and will stabilize even the worst of heroin addicts, almost all the worst of heroin addicts. There's very few cases where you need to go to 18 or 20, and I could specifically talk about those, but I don't think you need to. The key is the bottom there, and that is withdrawal must be suppressed, and you have to do that. That's the goal of physicians. You have to just suppress withdrawal. You're not trying to give them extra. You just want to get them so that they're comfortable for 24 hours. That's our goal as physicians. We want to give them enough medication so that they're comfortable for 24 hours. They're not half out of their mind running around trying to, you know, steal and scheme and lie and, you know, and trying to get more drugs. You want to get them to the point they're stable so that they can function. Because if they can function, then they can get better. Okay. I've been on methadone. Can I take Suboxone as a maintenance medication? Go ahead. Yes, you can. There's the conversion. That's very easy for me to say. I can tell you, in truth, it is very difficult to accomplish. Okay. Does Suboxone work for detox? And the answer is yes. You can detoxify any opioid addict off Suboxone. You can also be detoxified off Suboxone. How and when to detox somebody off Suboxone is not known. And let me just say a word about this, because I find that the judges were especially, and even I had a discussion with a very good physician in Ohio yesterday, were confused about this. A lot of patients, a lot of people think that when you get put on Suboxone, it's going to be just for a little while and then you're going to be weaned off. And that's interesting because we don't have any disease in medicine where that's the case. I've been using this example. You know, if somebody has diabetes and I put them on insulin and I get their sugar normal, as soon as their sugar's normal, I don't say, well, we got your sugar normal now, let's get you off that insulin. That would make no sense at all. And if somebody had high blood pressure and I got them treated with antihypertensives, got their blood pressure under control, we'd say, well, okay, your blood pressure's under good control, let's get you off those antihypertensives. We wouldn't do that. And yet in medicine, because there's this strong social stigma, there's this desire that people need to be on Suboxone for a short period of time. I've been to doctors who say, well, I put people on Suboxone for 6 months and then I wean them off. If they do that with absolutely no medical justification, and they do that based upon something about their own personhood that is not born in medical science. Right now, there is no imperative for somebody to be detoxified, to be weaned off either methadone or Suboxone. As a matter of fact, it's probably counterintuitive, it's probably counterproductive, and it certainly will likely throw a lot of people back into active opioid addiction. I've come to understand that opioid addiction, as serious a brain disease as it is a brain disease, and that it needs ongoing chronic treatment. And I think when doctors or the lay public think, well, this is just a short-time detox and then they'll go on their way and stay clean, is nice, but it's fairyland stuff. It is naive, and it is not the way it happens. These people need serious ongoing treatment, and I expect that there will be many people who are in treatment just like they would for any other disease for a long period of time. Okay? Okay, so how long do I take Suboxone? Some people, actually, when people come and they have opioid addiction, I usually give them their choice. Do you want to be detoxed or do you want to be placed into treatment? The ones that be detoxed, I do it fairly quickly. The ones that be placed in treatment, likely to be on it for a long time. But we don't know how long we don't really know if there's any length of time that somebody should be on the medication. Okay. Who can prescribe Suboxone? Any physician can prescribe it who has a certain DEA waiver. There's a lot of us now who do have this waiver. You have to go through a certain course and you can get it. Once you get through the course, then you're allowed to prescribe. Now, one of the things I want to say about that is that it's easy to get the waiver. You just have to go through an 8-hour course. The other requirement, though, is that if you're going to treat opioid addicts, you have to go through the course and you have to have the ability to refer them for counseling, which is kind of a crazy notion in and of itself, because I can tell you that without counseling, without therapy, just prescribing this medication, as good as it is, and it is, I want to make sure I say this, buprenorphine in 2013 is the best thing, I think, for in terms of medication, the best thing that's ever happened for opioid addicts. It has really allowed people to stabilize their life so that they can go back to work, get their families together, start clearing up their legal problems, and do things that I never would have imagined. In some ways, it really has put the fun of treating addiction back into my life, and I've greatly enjoyed it. But the medicine will only take you part way. The medicine is just the intro into addiction treatment. I would be really remiss if I didn't note that every one of the opioid addicts who I see have really complicated lives. They have emotional problems, they've got legal problems, they've got financial problems, they've got spiritual problems, they've got physical problems, and they all need some kind of treatment beyond the medication. If we think we're just going to give them a medication and say, boy, you're just a cute little drug addict and you just take this medication and I'll see you back, that is crazy. All these people need to be in some kind of outpatient ongoing treatment, both therapy and I think also 12-step programs too, and we use that a lot in our program. Anyway, go ahead. So do I have to go, this used to be a question, do I have to go inpatient to get in Suboxone? The answer is no. Nowadays you really don't, although if you have a problem with both alcohol or benzodiazepines and other drugs and you're on opioids, sometimes you have to go into the hospital to be detoxed. Okay? Do I have to be in a special clinic to receive Suboxone treatment? And if the answer is you do not, you can get it from any doctor's office, an addiction clinic, or sometimes from a methadone program. The treatment setting should have the ability to provide complete addiction services for Suboxone patients, and I don't want to understate how important those services are, and I would be glad to sit and talk about that, but you cannot underestimate how important therapy is. Okay? Does Suboxone have any side effects? And there are the side effects you can get from the medicine. The biggest one is it does cause sedation. Some people get sweating, nausea. I do see a fair amount of nausea people will get, but those are kind of the side effects you'll see when you first start Suboxone. All these are questions patients have asked. Go ahead. How much does it cost? It costs between $8 and $15 a day. Depends on where you get it. It's not cheap, but drugs are not cheap either. So, what are the benefits of Suboxone versus methadone? I think that they're substantial, actually. The first two are really important. Convenience of being able to go to a doctor's office cannot be overstated. For methadone, you have to go to a methadone clinic. Those are sometimes a long way away and not easily available. Doctors' offices are generally much better and easier to approach if you can find the right physician. The other thing is that overdose, safety. Methadone, it's fairly easy to overdose on, unfortunately. Suboxone, it is almost impossible to overdose on because of what I told you before. As you keep going up on the dose, it actually starts to work like an anti-opioid. Is buprenorphine addicting? And this is an interesting question because everybody means something different by the word addicting. Buprenorphine certainly Suboxone certainly goes to the brains of these people and stabilizes their brains so that they don't go into withdrawal. Rarely do any people ever get a buzz or a high from buprenorphine. It's just, I mean, there's a few examples where that can occur. Experienced addicts rarely get a buzz. If you are opioid naive, if you guys have never taken any opioids and I gave you some Suboxone, you might get a little buzz off of that. More likely you would get incredibly sick to your stomach and just puke, but you might get a little bit of a buzz off of it too. Okay. Why is Suboxone being sold on the street? And of all the things that have happened, this is the thing I'm probably most upset with, because I think this medicine is incredibly useful. It's being sold on the street for a couple of reasons. You know, addicts will take street Suboxone because it does allow them to feel normal. And you have to understand, for the average drug addict, if they can just feel normal today, that's a good day. Maybe tomorrow I'll find some hydrocodone or some heroin or something else. But, you know, if all I can find today is Suboxone, at least that's going to get me through the day. And so people will buy it off the street. The major source of diverted Suboxone are physicians who overprescribe buprenorphine products. And I have lectured and lectured and lectured about this issue. It's something near and dear to my heart. It's something that bothers me enormously professionally. There are some doctors who are either naive or poorly informed, and I suspect maybe even some who are mercenary who just overprescribe buprenorphine to their patients. And if you prescribe more Suboxone to a patient than they need, I can assure you almost with 100% certainty that they will take what and use what they need and sell the rest on the street. And it is a huge, huge, huge problem in a lot of the cities. I cannot believe how much street Suboxone is out there now. And it almost always comes because patients are on more than 16 milligrams and they're selling part of their dose. It's a big issue that needs a lot of attention. We have to figure out how to police this issue better. Okay. What about the Suboxone film? What are the advantages? I actually think the film is a great product. It dissolves faster, you get better absorption. I think it gets the patients away from the whole idea of taking pills. You know, for a lot of these people, that's part of their routine is just taking pills. The film is a whole different kind of product. Yeah, it's kind of funny. For the most part, there's better tolerance, but don't tell the Reckitt Ben-Keyser medical liaison, but it's easier to cut than the pill, too. That's an off-label thing. You're not supposed to cut the film, but in fact, you can cut the film. So if somebody needs 1.5, it's easy to do. When you cut the pills as 1.5, it was a little more difficult. But the film cut very easy. As it turns out now, we have new doses of the film that have just become available in the past month, so there may be less cutting going on into the future. You know, the price, right now the price has actually not been too bad. The company's been given some money, some vouchers, so that people were able to get the film relatively easily. Okay. So, this is interesting. This is a West Virginia law. I was just saying that. On or after September 1st, 2012, any practitioner prescribing or dispensing a combination of buprenorphine and naloxone to treat opioid addiction shall dispense product in the form of sublingual film unless the sublingual film is clinically contraindicated. That's the law. And, you know, I think inadvertently I had something to do with that, because I remember when they came around and asked me, I said, you know, I think the film's a whole lot better product than the pill. And next thing I know, it was getting written into law, which is kind of funny. I do think it's a better product, but I'm surprised we went to that length. Okay. What about side effects of the film? Very few. The major side effect you'll see in the film is people get sore mouth. They'll get sores under their tongue. And I've seen a few people with blisters on their tongue, and we have to switch them then. Okay. Oh, this is the real popular question from the patients. Can I still get drunk, do cocaine, and smoke pot if I'm on Suboxone? Thought like a typical addict, and the answer is, can you? Yes. Should you? No. No, you shouldn't. You're supposed to be trying to get clean. And in our clinic, we ask people to get clean from all substances: marijuana, alcohol, tranquilizers, cocaine. The clinic should really be focused on abstinence. It should not be just focused on people just getting off the opioids and then starting to stay on marijuana or stay on cocaine or whatever. People should be getting clean. Okay. Does Suboxone work for pain? Okay. Yes, it does. This is not a clinical indication. This is an off-label usage of Suboxone. The company would not approve of this, but the truth of the matter is buprenorphine initially worked as a pain medication, and it does work really relatively well for pain. Okay. Is Suboxone safe in pregnancy? This is another very off-label indication. Very few things are safe in pregnancy. This has been widely studied, though. As you might imagine, in this population of young people, we see primarily young people, there's a lot of pregnancy. In our clinic right now, we have about 380 patients. We have about 30 who are pregnant at any one time, 30 opioid addicts who are pregnant at any one time. All those young women, they're all on buprenorphine. And they do very well. Buprenorphine seems to be at least as safe as methadone. It is not approved by the FDA. It probably will never be approved by the FDA, although I might be wrong about that. The FDA, when it comes to pregnancy, just doesn't want to, they don't want to approve anything because it's so potentially hazardous. But we've had probably, I don't know, maybe almost 100 women now who have delivered at WVU who've been on buprenorphine and have not had any substantial problems. It's certainly been better than methadone. So it is getting used. It is not approved for that, but a lot of doctors now have begun to use it because it seems to be at least as safe as methadone. Okay, next. I think that was all the slides that I was going to show because I know that I wanted to be done by noon so that Angelo didn't come beat me or something like that. Does anybody have any questions or comments about any of this? I want to make sure that I don't minimize in any way the importance of giving Suboxone, of the complicated disease that opioid addiction is, and the importance of really providing a comprehensive kind of treatment for this. We are not going to have a quick medical fix. The good news is that we do have real treatment available in the year 2013 that we did not have available in the year 2003. And we have the opportunity, I think, to run really good programs and to help a lot of people. This is an enormous epidemic that really has taken its toll on educators and certainly the legal system and certainly the healthcare system. And so I'm feeling better about it over time. There's an awful lot of work yet to be done. Does anybody have any questions they might want to ask? Sure. Yes. He asked whether I've come across patients who are allergic to Suboxone. And yes, I have. It's almost always a lie. That's because they want to get the pure buprenorphine product. Suboxone itself, which is the combination buprenorphine and naloxone, is a much safer product. And patients, given the choice, I mean, if they could, they would like to get the pure buprenorphine because it's easier to divert and it's cheaper. And so I've had a lot of patients who say they're allergic to the combination. It has rarely been the case. I think in my experience I've had one person who I'm convinced was allergic to Suboxone. Every time we gave, and I made her go through this 3 times. She always, I see her in a group of patients, so she always brings this up how I tried to kill her. Because 3 times I made her take Suboxone, and every time she got a terrible rash. And so finally I switched her to the pure buprenorphine. She's the only one. There have been a few people who, when you give them the film, do get blisters under their tongue, and so you'll have to switch them over to the film. And one final kind of unusual problem that we've seen, but it's occurred with both the film and the tablet, is that there's occasionally somebody who's allergic to naloxone, the actual naloxone part of the combination. And when that occurs, what you'll see is really tremendous swelling in their lower extremities. I saw it in one man and one woman. And in both of those people, when I switched them from the combination buprenorphine naloxone back to just the pure buprenorphine, it went away. That's been known about for a long time, that kind of unusual reaction to naloxone, but you don't see it very often. So most of the time when patients say they're allergic to Suboxone, it's just because they want to get the cheaper, easier to divert medicine. So I tell them no. That's the short answer. Any other questions? Yes, sir.
This is a more general question. From what you're saying, is it safe to say that at least in some cases that addiction causes permanent structural and functional changes in the body?
That's completely fair to say that in some cases there seem to be, if not, the brain is kind of fluid, but there's so the brain can change over long periods of time. But in some people's cases, there's no question that the changes that occur in the brain are essentially permanent, and that the only way that they might change is if somehow you had a long, and we don't know this, I'm talking about months or years period of abstinence in which they might revert back to a different state. However, some people, there's a lot of addiction, there's a lot of genetic transmission of addiction. Some people were just born waiting for the alcohol or the pills to show up. I mean, I hate to say it like that, but that's kind of what happens. And those people, it's unlikely that their brains would ever go back to sort of an unaddicted state. I mean, this is a very complicated, that's an excellent question. And a lot of people don't realize that. They think, you know, if you just detox them for a week or two, their brain will be normal. It is absolutely not the case. If that was the case, everybody just quit. Okay. Yeah.
One more interesting question. It's kind of more like
I'm about to get the hook, so that's good.
biochemistry, like for example, SSRIs or SNRIs.
Yeah.
If the problem is primarily nucleus accumbens, and the answer is that people get high because they use dopamine release from those areas, why can't we treat addiction? I mean, other than the obviously blocking the opioid receptors, why can't we successfully treat patients then with the SSRI or SNRI getting the same dopamine release?
Well, people have asked that with Wellbutrin, which is much better with dopamine release. And they've also tried a lot of dopamine agonists. None of that stuff has ever worked very well. And I think it's because our level of understanding of the neurochemistry is not that good yet, or the neuroanatomy. It may be 10 years from now I'd have a different level of discussion, and we might be doing exactly what you're saying in terms of the medication. But we're not there yet. Okay. The hook has arrived.
No, I am not the hook. You don't tug on Superman's cape.
Oh, yeah,
okay?
right.
All right. Now, that's for our audience here. Hopefully I haven't destroyed my academics of this event. Doctor, this brings us to a very important segue on lunch, okay? But before that, there are many more things you need to know, and even if you knew them all, it would need to be applied to an individual patient. So you are advised, certainly FDA included, that you should never, even if you were talking to, no lawyer is a doctor, no doctor is a lawyer, you should seek professional advice from that particular person and not in a template, but in the individual facts. But you certainly now know, right, what you don't know. You know who to talk to and what to talk about. And that's the beginning of this journey. And doctor, again, we want to thank you so much for coming up here. Another segue. This is a disc. You can always get that from the nonprofit corporation, and you can listen to every speaker as much as you want. And we're hoping we can talk him into doing more of these so we go on to another volume or chapter. And we figure if we treat him real nice when it's time to show your expression of gratitude, I hope I can talk him into it again. If we don't, or even if we do, our humble little organization offers you this certificate of participation. I know it looks like any one of these you probably got more on your wall than you'd even be able to read, but there's some love and tender loving care in here. We have a seal on the bottom of this certificate. It's a raised seal so that nobody can duplicate it. Whoever we are, that's who we are, and we don't want somebody else to create a polluted, non-professional version. As the doctor said, anybody who treats without counseling is probably not. He was being polite. It's not a very nice thing to do. So we want to say that the people who work for us do the professional thing. Secondly, he's an independent. That doesn't mean anything I said is ratified by him. All of our professionals' opinions belong to themselves. This is for educational purposes only. The raised seal also, doctor, has our triangle with the outline of our building in the background. Everything we do is this trilogy. I'm standing in a Catholic high school, and I'll leave it there, what that trilogy means to me. The trilogy seems to work for us in legal, educational, and medical. He's already told you another trilogy: pharmacology, counseling, and hopefully legal. Okay? So that's where we're at, and this little certificate hopefully will remind you of a pleasant day once upon a time in Pennsylvania when you go back to West Virginia.
Well, thank you.
We have a hat for you that's the Signature Hill Independent, nobody works in a group, independent professional network, the medical division. Hopefully it'll keep you, I know you don't have any problem keeping the sun off your head. You have a full head of hair. I'm not meaning to offend anyone else out there. I have to tell you this, though, and I'll tell you off camera. Remind me, Dante, in 2 seconds. And lastly, I'm going to hold up for our camera and give to you what is the latest, and already that seems to me frustrating, the latest comprehensive research in law and medicine. It's all codified in this book here, National Association of Criminal Defense Lawyers, Justice Policy Institute, It's all in here. Now, I am also going to quickly say that most of the conclusions drawn by these articles in here are not shared by me or the people that we represent. They seem to be leaning toward legalization, talking about Portugal being a model, a country smaller than Rhode Island. Okay? This is precisely why I have a doctor like R Sullivan here to tell you now is no time to desperately quit and knee-jerk react back the other way and start legalizing things. I am an advocate, I'm an old prosecutor, and I never want to see drugs legalized in our country, including marijuana. That's an editorial opinion, but I'll fight it to the death. I will not accept as a private practice, which this isn't about, any issue on defending somebody saying marijuana is legal. It is not empowering that person. Anyway, these articles, Doctor, again, seem to be flavored with that, and I want to quickly say they're not. They're just given to you as a resource unit, not to support that concept. But there is some value, but there's probably about 300 footnotes in here with some really neat studies and statistics that might help you. I know that hopefully you thirst for knowledge all the time, and I don't know what you got from the legal community, but we'll try to keep you up to date on all of those things.
Very good. Thank you.
And lastly,
Have your hand there, buddy.
oh, thank you. Can we,
What?
legal and medical working together, right?
Hello, I am Dr. Jacqueline Respress, and I am the president of the Substance Abuse Coalition Summits. I come to you today to just talk to you a little bit about myself and the reason why I am involved in this project. As an administrator, as a teacher, as a counselor, I have spent nearly 40 years of my life invested in children and our community. Not only was I administrator in the local school district, I also am the wife of a pastor of a local church. Over the years, I found that our lives, the lives of our children, have been terrorized, have been attacked because of the drug abuse situation. And one thing that I found to be true, it does not matter who you are, what your race, what your economic background was. Drugs and drug abuse and alcohol abuse affects everyone at every level of society. One of the things that I have seen as I talk to friends and relatives and people who have raised their children and they just don't know what went wrong. But we find that our children are in the throes of these terrible times. We see grandparents now raising grandchildren. We see children being placed in foster homes because their parents are incarcerated. We see many, many devastating things happening to our families. And it is for that reason that I became involved in this coalition and took an active part in this war against substance abuse. As we merge together the legal and the medical and educational fields, we're going to present information to our children as a proactive view, hopefully to stop them from beginning any kind of adventure in the drug area. Secondly, we offer treatment programs and substance abuse information as well as behavioral counseling so that those that have already been affected can now seek some relief through not only a medical support team, a legal support team, but also through counseling. As we work together, we find that many of our problems historically have been dealt with in the schoolhouse and in the church house. And so I come to you as a representative of both, knowing that by working together, that we can work together to save those in our community that have been lost and sometimes that are struggling. But as the song says, some fall down, but the purpose is not to just fall down, but to get back up and to continue to stride toward the mark. We know that all things do work together for good for those who are in accordance and working together in unity. We can put this effort forward for those in our community, our schools, colleges, and to whatever area we need to go to, whatever the arena, so that we may present the message that we are projecting today. Thank you.
Good morning. My name is Chuck Adamo. I began my career in law enforcement in 1964. I've had a varied career. I retired in '91, and from there I wanted to do something completely different, at which time I ran for the office of County Commissioner. I won, and I was made the chairman. It only took me 4 years to realize that it was too much of a difference between law enforcement and politics. So I got out of politics and I went to the Sheriff's Department as a lieutenant. I was in the Sheriff's Department approximately 5 years, and from there I went to the position of Warden at the county jail. And from there I retired in 2009. However, what I'm getting at is, when I started in law enforcement, I'm from Newcastle originally, and they put me in Philadelphia. It was somewhat of a culture shock. But back then, in 1964, we didn't have the problems in drugs that we have today. They were more or less isolated cases. As time went on, I got transferred back to my home troop, which was in Newcastle, Butler Troop. And I worked in traffic for a number of years, and then I went into crime. By the time I went into crime, as an investigator, drugs were full-fledged. It was not only adults, it was not only men, it became the women, the mothers, the fathers, it passed it on to the children, and it continues today, and it starts maybe in the 4th or 5th grade, maybe just as somebody doing a delivery for an older friend. As I went on through my career and became a warden, it was very disheartening to me to find that the people that I had arrested in my earlier career, now their sons and their daughters were coming to jail, and it was for drugs. And it was kind of depressing to see these occurrences. You'd hear a name would come across my desk, and I would think back that I know that name, and do a little research. I did. I arrested their father, or I arrested an older brother or another relative, but the names stick with you. And everybody knows that the drugs doesn't matter whether you come from a good family, a wealthy family, a poor family. It goes through all aspects of every career, every family. You know someone who's either been on drugs, been arrested for drugs, or has died from an overdose. The program that they have today, through this program, you can see some light at the end of the tunnel. You have people who are genuinely concerned and who have proven that this program works for drug-addicted individuals. Something has to be done in the United States and all over the world because of the problems that you not only have in your families, but it's the townships, the country, the whole world. Something has to be done. Some way we have to curb this drug addiction, and through these programs that we're offering here, that can be accomplished, but it cannot be accomplished without all the help from every individual who's giving their time. Thank you.
Chuck, thank you very much for being with us, and Chuck is giving, we have your certificate here, and it's very important for you to know we didn't just pick Chuck off the street. We're assembling, our goal is to assemble this kind of dream team in members of our Substance Coalition. We're not doing customers, we're teaching people and making people aware. Chuck, once upon a time, was Lawrence County's warden. And how many years did you do that?
About 5.
Okay. And he was a lieutenant deputy sheriff, chairman of Lawrence County Commissioners. He was an elected official. Elected officials are very important to us because we have not got their attention yet. Because they're the people who have the political ability, and then hopefully after we talk to them, the political will to do something about this. So when we had a chance to entice Chuck to join our team, that gave it even more sizzle. And he's also a state policeman. And back in our old days when I was first practicing law right out of night school at Duquesne University, him and I did some cases together, and I don't remember us ever losing any of them. But we never felt good about people and putting people in jail. But we did feel good about separating our fellow children and citizens from danger. And that's what we're doing. If we can separate them from their drugs, we can probably separate people from danger and our citizens and maybe help somebody instead of put them in jail. And we're really honored to have Chuck as part of our group. And we know that keeping sun off your head may be a very important thing to you. And here's a hat for you to do that.
Thank you.
Thanks, Chuck.
Thank you.
Okay. Okay, our next member of our group and our coalition registry, and again, hopefully you're getting a flavor now for the fact that we're looking for people, but we're looking for not just any people, we're looking for diversity, and diversity in professional background. Our next person is a career professional educator, emphasize the word professional. He's also a coach, and I've known him for years. And what's important about being a coach? Well, my experience is I have found a lot of coaches to be passionate teachers. Sometimes teachers are teachers, and sometimes people are teachers who inspire. Ed has always been one of those people, and he's a caring citizen, and we're really glad to have him be part of our coalition registry. And it's an honor to share a podium with him, and I kind of twisted his arm and asked him to say a few words directly to our camera. So, Ed, thank you for being part of our group, and I'll turn the microphone over to you.
Thank you. No, I don't have any notes. I taught at Newcastle High School for 30 years and retired in 1997. Did spend 8 years out at Westminster in the athletic department also after that, and more or less retired completely now, with the exception of this new job that Angelo asked for a little help with. I was involved with the core team at the high school, and the core team dealt with at-risk kids and kids we suspected of substance abuse or problems with alcohol. So that pretty much started it, and I always wondered if I did any good or if our program had accomplished anything. And when I left, that pretty much ended it until Angelo contacted me again to see if there was any interest in helping out a little bit. I think the education part of our little triangle out here in front of me is a pretty important part of the new program. To let these kids know that there's people out here that can help them. And if we start with the kids and make them aware of what's available, then their parents hopefully are going to hear a little bit about it. The word spreads throughout the community, and that's what we're trying to do, get the entire community involved. So I'm here. We're looking obviously for some new places to show off our project, and we're going to hope for the best. So good luck to you. Thank you, and maybe we'll see you at your school.
Okay, we're back on camera, and again continuing in our journey to assemble as many peoples in this effort as possible. I have the distinct pleasure and honor to know that Dr. Robles has decided to join us and hang out with us, basically. And Reverend Robles, again, how long have you been a member of the clergy?
I've been in Newcastle for 40 years.
And you've been a member of the clergy?
For 45.
Okay, and you're still in Newcastle?
Yes, I am.
And what's the name of your church?
Oak Point Christian Center.
Okay, and we just need to dovetail onto what Father Lucas did so well on 3 or 4 occasions, and especially his presentation yesterday, which, by the way, I was told by at least 3 people that they thought it was one of the best parts of the entire presentation. Father, this is about empowering and using and directing the spiritual assets a person has, in addition to these physical assets people like Dr. Sullivan talk about, and incentivizing that with the power of the law after we found people who are ready. So hopefully you see some value in that, at least to start walking this journey with us and support us in any way you can.
Yes, the reason why, Angelo, I'm involved is because I believe that man is body, soul, and spirit. And when you talk to me about the physical and the mental, there is a factor in every man that God has created, and that is we are a spirit being. And I believe that when you mix these three together and add the spiritual aspect to it, you've created a tremendous potential of empowering people to be delivered and healed and have what we call in the church victory over their addiction.
Great, thank you so much, and we have a certificate of appreciation for your attendance and all that, and we hope to see you at our corporate board meetings. Thank you.
All right.
Brian Welsh is, again, another one of these acquisitions we've made in assembling this team. Brian Welsh is, again, a member of this team that we acquired years ago, and he's a friend. And those of you who are out here watching this on the web, and those of you who will watch it later in a multimedia piece, I am proud to say that Brian Welsh is part of our team, and we're just moving on and saying Brian's going to give you a little tiny background because we're due to start here very soon. But Brian, thank you for being part of our group.
I want to thank Angelo for the opportunity. I am going to be very brief because I know people are busy. I'm a part of this project specifically because Angelo's vision in terms of bringing separate pieces that have answers to the addiction and treatment problem. For far too long, we've been working in silos, each of us working as hard as we possibly can to do our best to provide answers and guidance to people who are addicted to alcohol and drugs. It's about time we rechange our thinking and we start doing things together. I believe absolutely one of the things that Angelo has is something that I felt for a long time, in that we've forgotten the person who has the addiction, and we talk around them and we devise solutions, and then we try and get them to buy into that. Okay? It makes a lot of sense in terms of what limited dollars there are to make sure that they're part of the planning process, because it'll save us a lot of extra money, but we also have to gain their commitment as being a part and a partner of this as well. My particular group of folks has expertise at designing activities that are very experiential. Experiential in the hope that the activity teaches what we hope is the lesson, and we step out of the way and let people learn. What we found is that they own the experience a lot more. Rather than just standing up here and talking and fatiguing people, because I could talk a long time, doesn't mean that I'm being effective. So we set up situations, we set up little experiments that people can actually participate in, and then use the experience as a way to anchor it into a far-reaching solution to the things that they're dealing with. I have to say that I've known Angelo for a long time, close to 12 years now. It's been about 10 years that this first concept came to Angelo. It was funny, in directing a nonprofit, I got sidetracked for a little while because of the needs of my agency, and fundraising becomes a big thing, and managing staff and schedules. There was a gap that I was not participating with Angelo. And I happened to be in a gas station and literally bumped into Angelo. And what was amazing was Angelo looked at me and said, "Hi, Brian. By the way, I remember when we were talking the last time," and he went on and on and on and told me about things that were going on. I finally stopped and said, "Angelo, you realize that the last time we talked was 2 years ago." And he picked up the conversation exactly at the point that I left it. Well, I want to work with somebody who's that kind of drive, that kind of vision. There's been two men in my life, Angelo being one of them. The other one was my father, that I've not experienced this with. And I find it remarkable, and it's one of the things that I'm proud to be associated with him. My father was a small-town pharmacist. And the thing about small-town pharmacists is it's almost like a priest confessional. Pharmacists learn a lot about the people who come to get their prescriptions filled. You know whose grandmother is sick, you know who's doing good, and whose son made the dean's list. You learn all sorts of stuff because people talk to pharmacists. And there are times when I would deliver for my father where people who were addicted would come in and beg for medication. And my father would refuse them. In fact, a couple of times he had knives pulled on him, people who were that desperate for medication. The thing about my father and the thing about that Angelo shares a characteristic is I never saw him in the time that he was alive, I never saw him be offended by anybody, even somebody who's holding a knife on him. He absolutely refused to be offended. I happened to have been with Angelo a couple of times when judges threw him out of the courtroom. And I've never seen somebody who smiled and said, boy, that judge must have had a bad day. And absolutely refused to take offense. And it's that drive, it is that constant drive, refusing to take offense, so that now some of the very judges who used to kick him out are now part of this team. And it's that willingness to start a revolution and not take offense. Because sometimes you have to invite people back 4 or 5 times. But when they come, they ask for a permanent seat at the table, and that's what we want. That's the value of this project. Don't be offended. Come with your opinions, fight for your opinions, and we have a real opportunity to take a step forward as a group. Thank you.
And Brian, thank you. And a couple quick disclaimers, Brian. I am not as old as your dad. Number 2, I have not been thrown out of a courtroom. Any judges you see in our program does not later, or that seems to work with us, you can assume safely that he threw me out of his courtroom or something like that. But again, thank you for your kind words. You're a real dear friend and a treasured asset to our effort. Thank you again. Okay, we are now, those of you online, we are now moving. We are very close to starting the official program, but before we did, we had extreme fortune to have a gentleman respond. And you know, it's really neat when you ask somebody to do something. I always try to leave them an exit strategy. So I talked to our next guest, and he actually had a very busy day in court, and he saw me in front of a backload of cases. And I went to his chambers and I asked him, hey, would you consider being part of what we're doing? And he's so personal. He's just a nice person. I mean, I just got done telling him, I mean it, you know, not because he showed up. He's a nice person. He's just a nice person. And he's always been involved in politics and government his whole life. And he said, you know what? And he actually, this would be typical of him to make sure he didn't hurt my feelings. He actually showed me his schedule, and I knew he was booked up and on call. And I said, wow. Okay, I know he didn't want to go, but at least he had an excuse, and he showed it to me and everything. And then he called me like a month later and said, something happened that I can come on Saturday. And that touched my heart, and I said to myself, I remember him touching my heart years ago when he was a state senator in Pennsylvania. And I said, that's who I voted for, and that's who I remembered. And that's just who he is. It came back to me again. And one of the major portions of our program is probably the shortest part. The opening ceremony that he did not get to see yesterday was a moment of silence for children who have lost their lives and police officers who have lost their lives in our country. And again, we don't have that answer to that. Those are pretty big problems. But we do know the answer is not denial. Denial is a river in Egypt, okay? Denial gets us nowhere if our elected officials don't have the ability to just deal with these problems, at least start a dialogue. And when he was a state senator, this would not be one of these neglected topics. So I said to myself, this is so neat that he came, because the opening ceremony is designed to show busy people in government, they don't have all that much time, in 1 hour, what they need to know. See, because until we establish a political connection, until our elected officials learn what they don't know and then translate that into the political will to do something about this, a lot of us are saying some very nice words that having no effect. So for him to come here on a Saturday already speaks who he is. And I thank you from the bottom of my heart, Senator Shaffer, Magistrate Shaffer now. Thank you, and God bless you.
Thank you. Thank you very much. Thank you, everybody. Thank you very much, Angelo. It's a delight to be here today. My name is Tim Shaffer. I am the district judge, we used to call them magistrates, in Slippery Rock. My home is in Prospect, Pennsylvania. I graduated from Slippery Rock Public Schools and then Penn State University and Duquesne Law School. And after doing a stint in the U.S. Army in Vietnam, yes, I'm older than I look, I know. I have been practicing law in Butler County for 38 years, except for 16 of those years in which I was a proud member of the Pennsylvania General Assembly as state senator. And I can recall back in those days that drug use and abuse, this would have been in the 1980s and the 1990s, drug abuse was not a primary topic of discussion as it is today. And it shows you how times have changed, and I dare say not for the better. So now I'm a district judge, and I see the beginning issues that are raised in criminal cases, particularly not particularly, but including drug cases. And I clearly am feeling very bad that the number of young people that appear to be involved, young people and not so young people who are involved with illegal substances, is clearly on the rise. And the toll that is taken on those young people and middle-aged people in some cases, and particularly their very innocent families, is really very depressing. I had a case, true case, where two 20-something brothers, they robbed not only their father's garage, but took their grandmother's jewelry. And when you fall to a point where you're taking your grandmother's jewelry, which wasn't very much as a matter of fact, you're in a real bad place. So how delighted I am as a former legislature, as a member of the bar, sworn to uphold the laws of the Commonwealth of Pennsylvania, and now as a minor judiciary officer, that folks like Angelo Papa and the rest of you professionals that are here today would take your time and energy and your volunteerism to try to do the best we can to, in our way, in our area, to put our country back on track. So I congratulate you, those of you who are within the sound of my voice. I wish you the very best of luck.
Okay, one of the, as you all know, Matt Mangino was on earlier in the morning, and those of you out here who are watching me and will watch me in the future, Matt Mangino talked about, various sentencings and sentencing issues. Just to throw this out to you lawyers out there, now you heard from him that is basically almost a violation of our ethical rules, the one on diligence, dealing with preparing and diligently working for a client. And spending enough time with your client to talk about the mitigators also, and the things like treatment that would help your client's legal interests out in addition to his health interests. Now, we have just spent a day and a half now with doctors, Dr. Neil Capretta and Dr. R Sullivan, who just left, two of the most famous addiction physicians probably in the country. And we have told you that generally speaking, when it comes to drugs, and it comes to a courtroom, you attorneys are faced with this scenario. You, number one, have a person who has a legal problem. You can, and I'm suggesting you should not, ignore the health problem and do the best you can and give him all the Sixth Amendment panoply of rights and representation and take him before the judge. When you get there, you will be in front of a county, depending on if you travel multiple counties like we do. You may be in a drug court. You may be in a drug court that's been abandoned. You may be in a situation where the court officially doesn't have a drug court. Whether they have a drug court or not, I believe it's incumbent that you make a cogent treatment argument. And a cogent legal treatment argument then puts that judge in a very difficult spot. And I've heard this personally from many judges who have successful drug courts. With no medical information about that client, how can we expect that judge to do justice and help the treatment and still protect people on the street? And I don't believe he can, and I believe it's shame on you because you're the attorney, you're supposed to present the case. That's been the essence of what we've been doing for 2 or 3 days, teaching you that there's these medical resources out here that Neil Capretta and R Sullivan head up, and legions of doctors like them. You need to have your client in a doctor's office because it's not just some spray canned treatment plan. It's a prescribed treatment document that you take to the court and help the judge make that treatment decision, help mitigate that sentence. Or let's suppose you can't mitigate the sentence at all. Let's suppose not one single legal benefit comes from this. We know that that defendant will leave incarceration someday, and he needs to know how to leave and not repeat this cycle. So, again, that's the dilemma that we think that judges face, and all the research that we have. And our next presenter is a doctor who works extensively in the prison situation up in Erie County. And gentlemen, would you like to approach, please? And we thank him for coming down. If we look a little disorganized, it's because we are. Not because we're disorganized people, though. We're disorganized because we've been putting this together for such a long time, and every once in a while we have busy schedules, and we try to make sure that we got people on when they're supposed to and when they're available. So at the last minute we were able to talk Dr. Into coming. I'm starting to lose my voice, and I apologize for that. Without further ado, I'm going to give you the microphone here, and he's going to speak to you briefly, and then we'll go to our next speaker, and Larry, maybe I'll have you do the podium after that. Thank you for being here, Doctor.
Thank you. I'm Dr. Skip Gilreath. My major process whereby I got involved in this is because I also do detox in Suboxone. But I am speaking for myself and not for any other entity or pharmaceutical company. My introduction as far as into medicine itself, I'm an osteopathic physician. I graduated from the Kansas City College of Osteopathic Medicine, did a rotating internship, and in 1973, 1974 through 1980 was my first exposure to drug addiction. I trained in a little place called Highland Park, Michigan in that period of time. Started out in general surgery, then again into neurological surgery. At that particular point in time, the homicide rate in Highland Park was the greatest in the nation. It was over 300 people a year. The amount of deaths related to drug abuse or drug addiction was to such a point that the county coroner, Dr. Spitz, was charged by the state of Michigan and the federal government for selling pituitary growth hormone, which was not the case. He was later exonerated. That left quite an impression on me as a physician, and as I started to get, I think I left off basically experiencing the fact that my biggest shock in drug addiction came through my training program as a resident. I can tell you that in the course of my numerous years there, that I've had guns pointed at me by police officers that arrested people that were in altercations with one regarding drugs. I've had an attempt to steal my car as I was riding in it. They just fall out in the middle of the street. It was a very, how can I say, a growth experience type of situation. Detroit, as you know, as a result of that, basically because of the recession with the car industry, is not the same Detroit that I had experienced. But it left a mark upon my soul, if you will, insofar as what drugs can do, and God only knows how much money was going through Detroit at that particular point in time in my training period. The only thing I can relate to you is that when we had the first Desert Storm, Detroit Receiving was our major trauma center. They took everybody out of there that was a surgeon or a critical care specialist to take care of the boys that were injured over in that incident. That's the experience level that was in Detroit. No other city in the United States has that experience. Having gone on from there, I would say, I would like to quote somebody very, Ron White, if you ever, I can't treat stupid, okay? And when people get involved in drugs, and I want to say, these are my opinions, you don't have to agree with me. It's sort of like 12 blind people trying to describe an elephant. Everybody's got a different part of the tusk. It's hard, it's round, I got the tail, it's small, I got the trunk. So this is my interpretation. My goal today is to insert some ideas. That's what neurosurgeons do. We take care of the brain. So I'm going to insert some ideas. You don't have to agree with me, but there are people here that certainly could make a change, I think, in the future. And my ideas are not necessarily are going to be driven to the fact that I would like to say we're going to change what's facing us, because as I will repeat in a few minutes, is that there's things we can't change. We're always going to have drug addicts. One of the things I want to address first, there is a book written in the 1990s called IQ by the New York Times. Anybody ever read it? Nope, that's okay. It comes in three forms. It comes the Reader's Digest, the textbook, and of course the Dr. Sullivan presentation, very academic. The thing I took away from that book is that we have more brilliant people in this country right now at any stage than we have positions for doctors, lawyers, and scientists. Well, if we have such a brilliant population, why do we have the problems that we have, the crimes? Why do we have the drug addiction? Why do we have the other social problems? I can't answer that question, but certainly when you have enough kids go through an elementary school or a public school and you have the data, where is education failing? Obviously, when you lock the doors, nobody can get in, but nobody's getting out. Who are we hiring inside to do the job as far as educating and making sure our children are getting the necessary skills that they can make the proper decisions in their future? They need a sense of belonging, they need a self-image, and basically a sense of direction. They don't need to be enabled. They don't need to be trained as puppy dogs. So I think if you're going to solve some of the problem, we've got to go back to the basics of education, giving them the skills that they need to survive on a daily basis. Next topic, next insertion of another idea. Anybody ever hear of Joseph Campbell? Well, he's a comparative religion. He's a man that spent 20 years going around the world learning about different religions. He was the big chief at Vassar College. He wrote a book on comparative religions, and I, being Roman Catholic and everybody else different, I thought I would pick one of his examples, the American Indian. And being in prison and doing the work that I do, I've had the chance to talk to what I call Native Americans. And they've completely lost their identity as far as their religion. Yes, we know about the peyote, yes, we know about the mescaline with the mushrooms and stuff, but these were their confirmation. When you're in a Catholic religion and many other religions, you have a confirmatory name. And if I ever had the opportunity to speak to a Native Indian, and especially in prison, I'd ask them what their confirmation name was. I don't have one. Then I ask them why they didn't follow through with any of the history or development of who they are as a people or as a nation. And nothing. How can you lose your identity? And went to school in St. Bonaventure University, not too far away. Olean, remember they've reclaimed the land. They've had their 100 years, and they're charging the Americans to drive across the highway. But how can you not identify? Where's your identity? Where's your focus of self? Where's your self-respect if you don't know where you come from or your religious beliefs? And this is why I think this is another cause of addiction, because our grandparents, our parents, and our community don't spend time helping them identify with this issue. Another issue that is very important in medicine, it's more important to me, and it should be important to everybody in this room. It's called continuity of care. Is anybody familiar with the Libby lawsuit? Libby was the daughter of a very prominent New York Times reporter. She was also a drug addict. She went to one of the local hospitals after shooting up and having a fine old time. She was admitted. An intern, female, excellent, top of her class. Unfortunately, when you have intern responsibilities and resident responsibilities, you're all over the hospital. You're just not assigned to one floor. Gets a call from the nurse saying that this patient was very combative, confused, needed something for sedation. An order was given for a medication. The medication was given, and within seconds, the patient had expired. Because of his prominence in the community, the hospital was sued, the doctor was sued. There was a charge that the doctor was too tired because she worked more than 48 hours, because at that time you have 2 days on and then a day and a half you take call continuously. Out of that, now resident training is affected to the point you can only work so many consistent hours and there's no continuity of care. If somebody comes in as diabetic, you don't follow all the way through until you've corrected the situation. You see everything in piecemeal. Out of this, we've had nurse practitioners, physician's assistants. Major complaint in any of the patients I have a chance to, I haven't seen my doctor in a year. Good question. So how are we going to treat drug addiction if we're having other people that are medical but not really non-medical address the issues? It's the clock hours that you put in as a physician to determine whether or not you're going to be a success to yourself and those you treat. It's not a 9-to-5 job. It will never be a 9-to-5 job. But Generation X has decided that maybe working from 8 to 5 is good enough. When we treat drug addiction, it's not just a, if you will, a psychiatric problem or a general medical problem. Medicine is compartmentalized to many different specialties. Drug addiction, as we've already been alluded to, is a chronic disease, but then again it may be just a symptom. So therefore you may need the necessary specialist to help you make that decision. Is it really a primary problem or is it a secondary problem? Of course, it's conceived as a chronic brain disease, and I have no problem with that. But with any of the chronic diseases that we treat, diabetes, hypertension, etc., it also can be a symptom. So as a physician that treats, if you will, drug addiction, not only you have to be aware of the psychiatric effects of it, but also what are the physical effects that may affect or cause the drug addiction. You just can't say, gee, it's genetic, or gee, I was in Vietnam, or gee, this doctor just wrote I had a toothache and keep giving me Vicodin, so I chemically got addicted. Because the drug culture, of course, does not really support that because they've already known somebody that's already taking them into that habit. Most likely, the most common drug is, of course, heroin. I'll take that back. Right now, it's grandma going into the medicine cabinet and giving it as a form of compensation, pain pills. This is something that's new. I guess the DEA guys that are out in the field don't like that type of thing, but they're no longer fighting the drug barons in Mexico and what have you as they used to. It's in-house. It's the doctors. I am part of this problem more today than I would say 20 years ago. The next thing is, of course, pain management. My next speaker, I understand, not my speaker, but is going to be a pain management type of individual. And while we're waiting for the microphones to come back live, when I talk about pain management, there's the time in the 1990s where it was treated as the fifth symptom. What's a fifth symptom? I don't know. There's all sorts of symptoms. But this is the time that people started to get a little more brave and say, I need something for pain. This is one of my problems. It's a symptom and I expect to be treated. Well, they weren't asking for Vicodin. They're asking for OxyContin. They're asking for morphine sulfate. They're asking for methadone. They're asking something that was not appropriate to their pain level. So we have now crossed the, if you will, the road not taken. We have big pharma and we have little pharma. Big pharma, Purdue, $4 billion worth of business, OxyContin. And that, I quote that from a DEA agent that gave a lecture in Erie not more than a year ago. Little pharma, ever hear of compounded pharmacy, potions, lotions, and stuff like that? I was riding my motorcycle in Sedona, Arizona. Sharp turn, the bike came out from me, I fractured a rib. And what I had left, I had my little potion, which is a combination of many drugs that you take orally, but you don't imbibe. Took care of my rib fracture pain for 6 weeks until it healed. I've also had signs and symptoms and intractable plantar fascia where I would limp, and I limped for 3 months and put these medications. We do have alternative besides pills. Pills are nice. Big pharma, everybody pushes them, but do you really need them? Why can't we just take care of the symptoms as they evolve and then move on? When we start giving medications that are addictive, and psychotropic drugs are also in that class, I know we don't mention them, but when you have patients that are on 6 psychotropic drugs plus Vicodin, you've got an addiction problem. Okay. As far as the most common symptom we deal with is cognitive dysfunction. As far as patients themselves, they're going to try to convert our programs. The things we have to worry about is taking somebody that has a drug addiction and convert it, say, like into an alcohol problem or a gambling problem. And of course, the other problem that we have by manipulation is counterfeit of urine specimens. And the reason why I say that is that what happens is you have to worry about diversion, and the only way we can prevent diversion is basically get urine specimens to make sure that we have the parent compound, but also the metabolite. So urine specimens, if we're going to have a drug addiction program, is a good way to control the problem. The office environment is kind of important, and what I'm going to say is I have the Harley-Davidson philosophy. My job, my vocation, believe it or not, is really driving my Harley-Davidson motorcycle. My avocation is basically the practice of medicine. So when the staff meets one of my patients, they're coming into the program, they're mentioned by their first name, how are you doing? Everything's very sociable, it's not detached. We try to make the patient feel very comfortable. Lastly, if we're going to really address this issue, continuity of care medically is important. A sense of belonging of that individual to the community and what he's associated with and his family, positive self-image. He's got to get out of the self-centered mode, and of course the last thing we should be doing is enabling. We should be training and teaching and supporting. Thank you.
Thank you very much, Doctor. Very informative. And Doctor, what prison is it again up in Erie that you're in?
SCI.
He's not in prison. Where do you work?
SCI Albany, and yes, I'm in prison 20 hours a week.
Okay.
Unless they don't let me out.
Okay, but before you leave, we thank you for being part of our little family and the people out there. All of our attorneys over here, thank you. And again, it's that connection, right, to the legal system. We have a certificate here recognizing your participation, and we make sure if you check if there's any misspellings or anything like that.
Excellent.
My secretary will certainly correct it. Thank you again, and we have, you're part of, we're not, this isn't about any team or anything like that, it's just a group who care, and this is your official hat, and you're a member of the medical division.
Okay,
it'll help you go through the day, and we look forward to meeting with you up again in Erie. We hear there's a large problem in Erie,
yes,
Pennsylvania, and you've got a federal prison up there too, don't you?
No.
Isn't there a, Mr. Ferletta, my DEA guy, he's not in here, he knows where all the federal prisons are. Okay, very good.
Thank you very much.
Thank you so much.
Thank you.
Okay. Thank you for helping him and making him feel good. And by the way, he was a last-minute add-on, and Doctor, we will not forget the fact that you jumped into this thing yesterday, as far as I know. Again, thank you. I look forward to meeting with you. Okay, now, we are now approaching a point where I would like to call upon our judge that's in attendance if he's available. And I know we took you kind of out of sequence there. And we're going back now to that position of that cogent legal argument connected to a judge. Interestingly, he was here yesterday. And that helps maybe explain this hodgepodge of our activities. And it helps because he's a former student of this Catholic high school. He certainly was a member of the bar and practicing law on the other side, and he is now a sitting common pleas judge. Yesterday, he was here as a taxpayer, just like we are. He's here as a fellow citizen who has family members that need to be kept safe on the street. He's a former student of this school. I know he's a rabid supporter of its future success, and he was here for that. And so why is he back here again today? He's here now as a judge. We're talking to lawyers in our CLEs there. And by the way, I did get all of your Supreme Court ID numbers and the paperwork to take care of that. Online now, you people out there are going to have to follow those instructions very carefully. And if you have any problem doing that, you call CAPE Institute. And CAPE Institute will make sure that you get proper credit. I'm not very technologically savvy, but their office will help you. The other people here physically, of course, we will sign them up. It gives me a great deal of pleasure to present a sitting court judge in Mercer County who will talk to you briefly, and it's probably more like even questions he may choose to have you answer. He's been here. He's already given us his community message, and he wants to talk to you as lawyers now. And thank you so much for coming, Judge St. John.
Thank you, Attorney Papa. Can I have a show of hands of who here is a defense lawyer on criminal defense bar? About half of you. As a sitting judge, it's a different perspective that we have when somebody comes in front of us for sentencing. In particular, most of you probably deal with them in that realm as well, but I recognize some of you also who do some custody and domestic work. Addiction, substance abuse doesn't limit itself to the criminal realm. It certainly jumps into all areas of law, and particularly the custody and the CYS type of cases. For those online, you should know that I'm a common pleas judge in a small county. We have 4 judges. We do not have divisions within our court. We all sit in juvenile court, family court, criminal court, civil court, at any given hour of any given day. So we also do not have a drug court. We have considered doing that, but we have other methods within our criminal justice system that seems to adequately address, at this time at least, the problems with substance abuse. I would welcome any questions at any time from any of the lawyers here. This is your shot at a judge to see how we think. To understand my answers better, it might help you to know that for 19 years I was a public defender in Mercer County here, and I can tell you that of the numerous people that I represented, that probably I can count on one hand, those people whom I would consider to be truly criminal individuals. I think most of these people are victims of circumstances. Some are the stupid that you can't fix. And so many of them are people that just fall into substance abuse, and so many of them are people of mental illnesses. When people come in front of us for sentencing, oftentimes it's very difficult to determine, as the doctor indicated, what the underlying problem is, because there are so many different aspects to this individual's problems, and there are so many overlays between the addictive personality, the mental health issues they may face. A lot of times they're loaded with medical issues, and you don't know what's causing or feeding the other. And most of the time when we finally impose sentence, we do not know the answer. I can't recall ever, in the 9 years that I've been on the bench, having any defense lawyer present to me a treatment plan, as was indicated earlier. They have given me bits and pieces, basically to describe an individual's problems over the year and what programs they've been in or what drugs they've been in. Mercer County is one of the 2 counties in Pennsylvania that does not have its own adult probation and parole department. We still have a contract with the Pennsylvania Board of Probation and Parole. So prior to sentencing, we have all of the defendants, except for some real minor level defendants, undergo a pre-sentence investigation by the board. And they submit to us a report that's usually 5 to 10 pages, depending on the length of time this individual's been in the system. That does contain some treatment information, but very little. Most of the time, the lawyers, it seems, in our county have relied on the judges to grab the bull by the horns, and at the time they enter a guilty plea or are convicted, if there is an acknowledged substance problem or a suspected substance problem, we will order a drug and alcohol assessment by the Mercer County Behavioral Health Commission, which is our central agency that has somebody in the county jail to conduct drug and alcohol and mental health assessments. These are entry-level assessments. They're not psychiatric or psychological evaluations, but they are very helpful. And they typically will give us a very short report, usually 1 page, that has a recommendation for treatment. And from there, we try to follow through with that at the time of sentencing. So it would be helpful for attorneys to present a more cogent and perhaps a more organized treatment plan if they can come up with one to help us out here. As you know, I'm a graduate of this high school, and probably my Catholic upbringing has some play and some role in how I view my role at sentencing. That means that when I look at an individual that stands in front of me, I do not see them as a criminal. I see them as an individual who has a mental health issue, a drug addiction, an alcohol addiction, or a combination of all of that, or who's just basically lost in life. I do use my jail sentences for a couple different reasons. One, as a way to bully or coerce an individual to be compliant with a treatment plan. That usually happens when they have already been on probation or parole and reoffend, relapse, which we expect. Then we try to address that issue. Sometimes I use jail time as an opportunity to be clean. And depending on the length of time somebody has been abusing themselves with these substances, whether it's alcohol or drugs, I may keep them longer because that's the cleanest time they have. And you can't believe the difference in the people's eyes when they come before you after they've been in jail for 6 months or 3 months. I get numerous letters from people all the time in mostly the county jail, believe it or not, thanking me that I put them in jail, because typically when they get to that point, it has actually saved their lives. But there are no magic answers. There is a huge gap between leaving the jail and starting treatment again. And the main problem I see it is funding. Most of these people are going to have public assistance to take care of the cost of their treatment plans. When you're in jail, you can't have public assistance, obviously, and you have to go out and open up a new application and get all reassigned. People on SSI or SSD, they lose that when they go to jail. So we've created a big vicious cycle here where now they've got to get reapplied and set up again and recommence their treatment plan. So you have that gap. I don't know, if I was them, I probably would want to go party the first day I get out of jail, because it's been no fun and I want to have fun again. And they're going to go right back into the community and see the people and be in the places where they've been all this time. So it is a vicious cycle. There are some great programs and opportunities out there for people. We do use inpatients frequently. It's all taxpayer funded pretty much. But there has been a decline in all funding for the implementation of programs for those people who need them the most, from the mental health all the way down to just somebody who has a basic problem. I would also observe that there's probably about an equal amount of people who come before me for sentencing where there's a substance abuse problem, that alcohol is the problem as opposed to drugs. I don't see drug problems as being the overwhelming issue. I mean, I view them both as substance abuse issues and addictions. But a lot of times we have this common perception in the community that it's really, the jails are filled with drugs or drug addicts or drug pushers. And typically that's not true. As far as drug dealers go, there are many of them who are very low level who are actually addicts. And in order to support their habit, they may go out and buy 10 rocks of crack cocaine and sell 9 of them to recover their money, and then use the last one for themselves and then continue to do that. They're all obviously part of the problem, but I'm going to view them at sentence court a lot differently than I will the person who is dealing in drugs who does not have a drug addiction or an alcohol addiction, and who's basically making a living or trying to make a living on that. There's other reasons that some of those people do that, socioeconomic reasons, but all those factor in, as well as the sentence guidelines that we have to follow, in determining whether they're incarcerated, and whether they're incarcerated in the county facility or if they go to the state penitentiary system. Obviously, the state penitentiary is the choice of last resort, not only because the governor wants us to view it that way, but because that's the only fair way to do it. People ought to be given an opportunity. Most people send lots of letters before sentencing, redeeming themselves, claiming how they'll never do it again. And it's difficult to discern who is in front of you really ready to respond to treatment or not. Sometimes you just give them a little bit of rope, knowing that you have that leash to pull them back when they're on parole or probation if they reoffend, and to whack them then if you need to do that. If there's any questions, I'd be happy to listen to them now and answer them if I can. Obviously, I can't comment on any cases you may have in front of me at this point. But this is a great idea that's coming together here. Attorney Papa's trying to bring together the professions. There is a great need for judges to be educated on Suboxone, because we see that a lot. There's other clinics like Methadone Clinic, and my understanding is Suboxone is pretty similar. But we don't get that information fed to us. We do have opportunities twice a year to go to conferences, one in Philadelphia and one in Pittsburgh. There are 2 or 3 day conferences where they bring in physicians and other people in the fields to educate us about what's out there. But no effort really exists to bring us all together, mandatory education for judges to say, look, Here's the science on this. Here's the medical explanation on this. Here's how you should treat them at sentence court. So what I'm giving you is my view. I think most judges probably take a similar view as I do, but we all have different philosophies and different life experiences, and we'll drop the hammer for all kinds of different reasons or not drop it for different reasons. So we do rely on the attorneys to help us deciding who and when to drop the hammer. Thank you.